Thank you for taking the time to join in for this recorded talk. I'll be covering some of the details I recently shared during my Chief Medical Officer's update with the Sandoval Regional Medical Center's Board of Directors. For those of you who I've not yet met, I've been a part of the UNM SRMC team for the past 4 years, and my clinical time is spent caring for patients on the inpatient wards as a hospitalist. I was raised in New Mexico and find myself fortunate to serve a community to which I have so many ties. During this talk, I will broadly cover several topics all tied to COVID. I will start off with state trends and new policies, as these macro trends help us to set the stage for recent trends within Sandoval County and at SRMC. I'll also talk about the crisis standards of care and vaccine updates, and lastly, close out with some information about what every community member can do to help hospitals in their areas and links for professional well-being. As we begin with state updates, I would encourage you all to visit cvmodeling.nmhealth.org. Here you're going to find much of the information I will be covering regarding state updates, and this gets updated every week. This slide shows how many patients we are testing per 100,000 in our state, and you will see that high testing rates continue for New Mexico, and this is a notable success for our state. Even since the early days of the pandemic, when we look at per capita testing, we have been consistently high and often in the top 10 per capita for the US. Here, you can see that we are currently coming in at 6th, and the more testing we are able to do, the more we can understand about the prevalence of COVID in our communities. Here we see some of the results of that testing, and the black dotted line shows our 7-day averages. I would state that while it appears this line is starting to go down if we look towards the right hand of this graph, the data often lags and is not considered complete until it is outside of the gray zone. Further, a trend you will see here, as on many slides, is that while there may be the earliest signs of leveling or plateauing, we're not anywhere near where we were in the spring and summer if you looked more towards the left of the graph. Thus, while cases are at least not climbing, we certainly are not out of the woods and have a ways to go before we mirror where we were in the spring. Here, you will see a similar trend that shows COVID cases by age, demonstrating this is affecting everyone, regardless of age. All those different colors, if you look towards the right of the graph, correlate to a different age group. And again, while cases may be coming down, they unfortunately got to record highs. The areas in gray reflect data that's still being collected. In the past several weeks, when we look at positive cases per 100,000 as compared across the US, we have usually been falling between a 22 and 28 overall ranking. As you can see in this graph, we're currently at 24. In the beginning of December, the state instituted a new state gating criteria for reopening: red, yellow, green. Now, red means a rate of greater than 8 cases per 100,000 during the most recent 2-week period, and being the operative word, an average percent of positive COVID cases of more than 5%. Yellow, which is high risk still, means either or one of those 2 criteria were met. And then green, which is, please still note, a medium risk, means both these criteria were achieved. Unfortunately, at the time of this recording, most of the state is red, and hopefully January will bring forth some yellow counties. Most recently, Sandoval was approximately at a 12.2 positivity rate and 73 per 100,000. So a long way for us to get to that 8 per 100,000 and less than 5%, which would mean a green if we were able to achieve both of those. This graph is very telling, and this graph highlights the total number of hospitalizations in the state of New Mexico. You will see upon the left and y-axis, there are a number of hospitalizations ranging from 0 to 1,000. And we saw as many as 950 throughout the early part of December. Now, the salmon color reflects the patients hospitalized without ventilators, and the teal represents the number of cases who are utilizing ventilators. As we discussed earlier, the most recent data would suggest some plateauing, but we far exceeded the number of cases from the summer and the spring. where you can see that we never really exceeded 250. And looking at this, you can understand that hospitalized cases have almost quadrupled in the state. In a few slides, I'll talk about some of the guidance the state has provided on how to deal with the significant increase, which is taxing all hospital systems throughout the state. We, as all hospital systems, are hoping to come down from that high mountaintop and blunt the spike. With the recorded hospitalizations, you can see the members of those age groups who are actually being hospitalized. So this is on the left side, you'll see the percentage of new hospitalized patients each week, with the purple and green correlating to the age group. Using the key at the bottom, we can see the vast majority of hospitalizations include those in the age ranges of 35 to 64 and older than 65. Every day at SRMC, we analyze our data daily and have real-time analytics to provide us the most up-to-date information in our hospital and from all around the state. This is simply a snapshot of where we were in the early part of December, which is reflective of the graph of state hospitalizations we just saw with the salmon in teal. Now, in the early part of December, we saw almost 65 to 70% of our total inpatients were related to COVID. To put the recent surge in perspective for us, we saw roughly from the middle of November to the middle of December, almost half the total number of hospitalized COVID patients we had seen the 8 months prior combined. Given the significant increase and almost quadrupling of the hospitalizations from the spring, the state has provided and helped with a framework for promoting fairness and consistency in healthcare delivery throughout the state, and that is the crisis standards of care. These are some great links, and I encourage you to look at them further. There are several documents that provide a deep dive into the crisis standards of care towards the bottom of the page if you follow the first link. The second is a short video from a recent press conference held by New Mexico Human Services Department. It features Dr. Scrace along with Dr. Gonzalez and Dr. Richards from UNM. Many of the slides and information I'll be going over can be found through the first link. In the framework that the state provided, they helped define the continuum of care or different operating levels of all hospitals. The 3 levels are conventional, contingency, and crisis. Currently, all hospitals throughout New Mexico are operating in contingency. This means the hospitals have surged beyond their licensed bed capacity and some resources are becoming scarce. All hospitals in this phase are using their established emergency operation plans. These plans help provide specifics about the mantra of this phase, which is to adapt, conserve, and augment. Each hospital does this a little bit differently. At SRMC, we've adapted new space for providing care in the ICU. We've done this by reallocating other operations that occurred in the ICU, such as dialysis, to other parts of the hospital. We have implemented several conservation strategies around scarce resources such as PPE. We've augmented our care teams by bringing in new staff and reworking workflows to allow for optimal efficiency in this phase of contingency care. What we have also done in this phase is increase both our incoming and outgoing transfers as medically dictated. The transfer strategy is a key component for many quote-unquote non-hub or spoke hospitals to maximize their contingency phase and avoid moving into crisis. This hub and spoke relationship is from the state's framework, and I'll walk through some of the key features of this relationship. As a spoke, we at SRMC keep the hub updated on any changes of status or specific needs and coordinate transfers with the hub. We're also prepared to support the hub in a situation of census disparity, and this is us accepting transfers from them. The role of the hub here on the left is a bit more and entails several other key features. Some of the most salient points are to support the spoke hospitals as a higher level of care. Often the hub hospitals have more resources and the presence of subspecialty care, which many spokes do not. The ongoing hub and spoke relationship is maintained by a central line and that the state has helped set up and many medical professional staff. This helps any spoke hospital speak to one of the hub hospitals and vice versa. Here on the map, you can see a breakdown of the spokes and their hubs. On the chart on the right, you can see the different hub regions that have been established by the state. You can also see the traditional or conventional ICU space that is associated with each region of the state, as well as their increase. Now, this reflects their ability to operate in contingency mode. They create this capacity by following the key principles, which is to augment, conserve, and adapt. The link provides an interactive map that can pull up further details about the hub and spoke hospitals. Here is a brief listing of the hospitals that are within the central region. As you can see, the three main hub hospitals are UNMH, Presbyterian, and Lovelace. In the spokes, you'll see hospitals that are affiliated with these larger health systems, but there are also several other independent health systems which refer to the hubs as well. This slide again shows the continuum of care that we've discussed previously, but in a more straightforward fashion. In short, we can see when resources equal demand, we're in conventional care. As there is an increase and significant stress on resources, as well as increasing demand, we would consider that contingency care. And lastly, when the demand exceeds the resources, we would consider that to be crisis. And in addition to our previous principles of adapt, conserve, and augment, some new principles that we employ in crisis revolve around what you see here in red: allocation and triage. What you will also notice is each hospital system has triggers and indications that have to be met before they move into another continuum of care. I'll be talking a little bit more about the transition from contingency to crisis in the upcoming slides. For hospitals to move from the contingency level to the crisis level of care, a few things must be done. The first has occurred. The state has declared the crisis standards of care and outlined how an allocation and triage strategy would work. Again, you could read more details by following the MAT link, which I referenced earlier. The second step that must occur is the capacity of a scarce resource at the hospital must be exceeded. The third condition, which must be met, and this is again is why that spoken hub relationship is so important. And this is how we level load, and ultimately we ensure that one hospital is not operating in crisis standards and say another in conventional care. This is how we make sure that throughout the state, we are utilizing all of our resources at all of our hospitals are operating together, and we're ensuring that all New Mexicans receive the care that is dictated by that continuum of care model. So if this criteria is met and the hospital states there is nowhere to transfer the patient, then the local triage board decides on the implementation of the two key additional principles of allocation and triage, as mentioned and provided by the state. As you can tell, prior to implementing the crisis standards of care, a number of triggers must have been met. Talking a little bit more about the triage and allocation protocols that are set forth, I wanted to take a step back and discuss the idea of triaging and allocation is not at all new. The crisis operations is a phase of operations we are trying our best to stay out of, and I greatly appreciate all that you are doing to help reduce the spread of COVID-19 during this time in the community. I simply included this article that you're seeing now to highlight the headline and the date. This came out in November 2006, which was approximately 14 years ago. Healthcare professionals have been thinking and talking about crisis standards of care and how to operate and ensure quality of care with optimized outcomes for many, many years. The process of triaging and risk stratification is something that all clinicians practice on a regular basis, and they do this through a variety of different tools depending upon their specialty. One is called the Eastern Cooperative Oncology Group Performance Status, or ECOG for short, which gives an oncologist an understanding of which therapies are indicated and which will ultimately be harmful to the patient or not change their outcomes. When it comes to another scarce resource for other subspecialties, such as organ allocations for livers, we commonly employ the Model End-Stage Liver Disease Score, or MELD score, to help improve our organ allocation and craft appropriate treatment plans for those patients. The foundation of our current crisis plan was based on the Institute of Medicine standards following the 2009 H1N1 epidemic. This foundation has been built upon over the past decade through several other documents, which can be found through the MAT link I referenced earlier. While all these are notable, I would just like to focus briefly on the 2020 Acute Care Medical Surge Plan for the COVID-19 pandemic. This covers many of the items that I've been talking about, such as contingency operations, the hub and spoke model, and some of the ethics that I'll be discussing now. These crisis standards of care are required because the ethical and legal obligations of all healthcare providers shift during a crisis of this kind and magnitude. Now, normally, healthcare providers have an obligation to their patients individually, and both law and ethic councils note that providers are to offer what is best for their patients and then to provide that care chosen by informed patient, loved ones, and shared decision making. Under the crisis circumstances, there may be times which certain scarce resources, such as ventilators, intensive care beds, will be in short supply and cannot be provided to all patients who choose that care, and thus they cannot be offered to all patients. In the crisis standards of care, there is an obligation to the public good to do what is ever necessary to save the most lives. Now, the allocation method for scarce medical resources will be fair, consistent, and transparent, and the state has assured of that. Being fair means that all patients across the state are subject to the same allocation procedures, and that allocation criteria are based solely upon objective clinical considerations. When it comes to this pandemic, a majority of triaging will revolve around the SOFA score, which will be used against the backdrop of their comorbid conditions. The SOFA score is an acronym for Sequential Organ Failure Assessment. The duty to care for patients always is the obligation of healthcare professionals. This obligation requires that the patient-provider relationship be maintained always. No patients will be abandoned in crisis standards of care. In an extreme disaster with scarce resources, it's understood that all patients may not receive all levels of care available, but all patients will receive a level of care available that speaks to the hospital resources and their objective clinical status. For the crisis standards of care in New Mexico, again, this provides a legal liability standard to be applied to healthcare providers during the crisis. It provides a consistent way in which providers must triage patients when they are inadequate healthcare resources, and we've talked a little bit about that scoring tool. Statewide triage officers for the statewide transfer center have been allocated, and there's also local triage boards with local triage officers at each hospital. At SRMC, this is just an example of what a triage board may look like. Our CEO is present, as she does have a notable medical background. You also see our chief nursing officer, as well as myself as the chief medical officer. We also have representation from ethics, legal, and our Office of Native American Affairs as well. Again, those triage officers that you're seeing below will be identified at the hospital level. They'll help problem solve with their teams and local boards when the hospital has enacted its crisis operations, along with the continuum of care if and when it feels its resources cannot meet that demand and patients cannot be transferred to a higher level of care. The state protocol provides both local and state collaboration by using a validated clinical scoring tool. The protocol that the state has outlined clearly does not permit at any time any consideration for gender, race, ethnicity, religion, social status, age, education, sexual orientation, physical or mental disability, employment status, immigration status, social worth, value to the healthcare system, existence of dependents, or consideration of insurance. All of these are ethically irrelevant to making the objective allocation decision. I will now segue and talk a little bit about vaccines, in particular the BNT162b2. I would again encourage you to review all the links I've listed here from NEJM, the FDA, as well as the CDC. So this is commonly referred to as the Pfizer vaccine. And again, this is BNT162b2. Participants in the study were all over the age of 16, and the protocol called for 30 micrograms to be given approximately 3 weeks apart. As many of you know, the temps for long-term storage are quite cold, between -80 to -60. However, it can be kept at warmer temperatures for up to 5 days with the lipid nanoparticles and mRNA still being stable. In the trial of roughly 43,500 patients that you see here, roughly 22,000 received BNT162 B2, while the other roughly 22,000 received the placebo. Of note, I'd like to call attention to the age range that received the vaccine, noting that almost 20% were 65 and older. And this is key, as we know that this is the group with the highest mortality. So the study was not designed to assess the efficacy of a single dose regimen. Nevertheless, in the interval between the first and second doses, the observed vaccine efficacy against COVID-19 was approximately 52%. 7 days after the second injection, however, you'll see that there were only 8 cases in the vaccine group with 162 in the placebo group. Overall, this was very well tolerated. You'll see the percentage of participants there on the y-axis, and pain at the injection site, fatigue, and headache here along the x-axis. Again, this is for ages 16 to 55-year-olds with the first dose. After the second dose, some of the side effects were slightly higher for the vaccinated group versus the placebo group. Looking at the same data again, now for those over the age of 55, you'll see there's a relatively safe safety profile, and overall this vaccine was well tolerated. Overall, the efficacy was thought to be approximately 95% after 7 days of the second dose. I would state that the efficacy is obviously not 100, and even in those vaccinated, must maintain social distancing, good hand washing, continue to wear the mask, and doing all the great things that you've been able to do thus far. I would say that the adverse events that were notable were similar between placebo and the vaccinated group, approximately 0.5 and 0.6% in those respective groups. One concern that has been raised on several different occasions has been the concern of genomic integration. I just wanted to emphasize that the lipid nanoparticles at this time and the messenger RNA at no time goes into the nucleus at any point that is now known of. The messenger RNA and related protein synthesis occurs in the ribosomes and is ultimately degraded after a period of time. The distribution plan is to first vaccinate all of those who are on our front lines, and that includes EVS, techs, nurses, physicians, really everyone who helps with the day-to-day care of COVID patients. And if you go to the CDC's website, you'll find more information about their tiering, and that is a tiering plan that we are adhering to. SRMC is also participating in regular frequently asked questions and updates with our daily email communications to staff. It is not mandatory, however, it is strongly encouraged, and we are receiving weekly shipments and allocating based upon those weekly shipments. I have great appreciation for all those on the front line and all those who've been affected by COVID. I hope by this time, since we're almost in month 10 of the COVID crisis, that most folks are familiar with the New Mexico Crisis and Access Line, as well as the Office of Professional Wellbeing. And if you're not, please take a few moments to go through these links and visit their websites. The New Mexico Crisis and Access Line has a great phone app, and the Office of Professional Wellbeing has several initiatives for faculty and learners that further enhance our culture of compassion and promote personal resiliency. They follow Stanford's wellness model to help stem physician burnout, and they also have weekly Zoom sessions and support confidential peer-to-peer system as well. So a recap, I know this has been a long talk, and I greatly appreciate your attendance. In short, the state's doing better in blunting the spike, but we still have a ways to go to see where we were in the spring. The reopening is based on science. of infectivity through our red, yellow, and green strategies that we talked about. The hospital remains focused on contingency, which is adapting, conserving, and augmenting. We are in regular communication with our hub hospitals. If and when crisis standards of care are needed, the infrastructure provides transparency, equity, and ensures stewardship of scarce resources. And that's greatly appreciated of the state was such a great partner in providing all of that infrastructure to all hospitals throughout New Mexico. The vaccine rollout has started and will be occurring on an ongoing basis for healthcare professionals and will ultimately include other folks as well as time goes on. All staff are encouraged to review the resources through the Office of Professional Wellbeing and the New Mexico Crisis and Access Line website. Please remember, even if you've been vaccinated, still be mindful of social distancing, remembering your PPE while you're out in the community, hand washing. Please take cautions while shopping. And during this holiday season, please think of modified ways to celebrate the holidays and be adherent to travel restrictions. Here's another list of resources that I shared. And in closing, I just want to say during the pandemic, I know that each and every clinician has made adjustments to their routines. I realized during this time, more so than ever, critical information is changing literally every day. I know by the time this is watched by many of you, there'll be even more stats and even more guidance and information about the vaccine, and perhaps even more guidance from the state and updates from the state as well. So I just wanted, in closing, wanted to say I'm amazed that every day providers continue to find new and inventive ways to deliver excellent care to our patients. I personally thank you for your ongoing efforts, and I wish you all a socially distanced, safe, and wonderful holiday season. Thank you again.